we may have a few more people joining, but in the interest of time, and to honor being on time, let's begin. So this is Boris Kalin from Hospital Quality Institute. I'd like to welcome everyone to the Engage Track 2 webinar, Engaging Patients and Families to Prevent Surgery Complications. I believe we have some new people on the webinar today, so let me just mention that in Track 2 we are providing advanced learning opportunities for those hospitals and systems that would like to engage families as their partners in safety and quality of care, which is different than our Track 1, which is working to build patient and family advisory councils and other formal opportunities to engage families and patients in operations and improvement as well. But this track focuses specific to safety and quality outcomes. And today is the fifth of our deep dive webinars, which we are focusing on how we can engage families to support successful surgery outcomes. Our previous webinars included engagement to prevent things like readmissions, medication error, infections, and patient falls. And then we have two more webinars coming up to wrap up the series, and we'll talk about that at the end. Logistical information about the webinar today: we are recording it for future reference. You should try to mute all of your lines just to prevent background noise, because we're keeping all the lines unmuted on our end for the most part, unless we have to mute somebody. And use the chat function to ask questions and make comments. You can direct this to any individual person or the whole group. And as every time, we want to make sure that we know who is in attendance today. So I would like now to have everybody type into the chat box the names of who is attending as part of the group. So again, if you could type into the chat box the names of everyone who is part of your group, and especially we want to capture those people whose names are not showing up as being logged onto the webinar itself, because we only can have one person logged on. And this is the full schedule for our Track 2. I want to remind you that all this and program and all other program material is available on our member portal, which is part of HQI's Engage website. And a brief mention of our coaching calls. We still have an opportunity to help guide you through some implementation steps and processes and tools of this kind of engagement. We have an opportunity on August 4th from 10 to 3 to schedule a time to spend on a coaching call with Karen and potentially also Mary. And if you'd like to schedule that call, ask me at the number that's on the screen. I also want to make sure to invite everybody to attend our capstone event, which is scheduled for September 16th. It's not showing up on the screen, but just suffice it to say September 16th is our capstone event. It's going to be hosted at Sutter Health Facilities in Fairfield in the Bay Area, and it will provide program closure, learning, and exchange for both Track 1 and Track 2 of Engage. And it will be a showcase, basically, of everybody's good work and achievements and barriers and how they've overcome barriers and implementing this agenda for, again, Track 1 informing PFACs, and for Track 2 in engaging families specific to patient safety. And for those hospitals that have been part of a formal part of the program, HQI will provide travel support, and for other hospitals are certainly welcome to attend. However, we cannot offer travel support to help you attend. And look for more information to come on the capstone really soon with the details. We also would like to have hospitals showcase and formally present on their work, and so more on that to come as well. Here are the topics. A reminder that we are focusing on those safety topics that are part of the CalHEN, or California Hospital Engagement Network objectives, and you can see all of them here. The program today has been approved for continuing education credits for nursing, healthcare executives, and healthcare quality. To receive credit, just make sure that you complete the webinar evaluation at the end of the webinar, and then give all the information that it's asking you for the continuing education credits. You can see at the bottom of your screens, this is something that we're trying new. This time you have a webinar survey link, so the survey link is right there. It should take you right to the eval survey, and as well as the final slides that we're showing today. If you need a copy of them, you can download them straight from the screen. And Mary, were you going to touch on the objectives?
Yeah, I think it's important for us to do it. This is Mary Foley. Hi, everyone. Thanks for joining us and for all the hard work that you're doing. I wanted to just clarify a little something in the first objective. These were produced much earlier in the process, and when we had a chance to do a planning call among ourselves, we realized that we're really not here to help you avoid surgical complications. I mean, that would mean we're going to teach you some surgery today, and we're not surgical experts in that regard. We have a family member and a social worker and an RN talking to you. So the terminology is probably to help to engage patient families in supporting surgical recovery and the reduction of adverse events. So, you know, just for clarification, I hope you aren't on the phone hoping to understand how to reduce a surgical site infection by your next orthopedic surgeon, because we're not going to tell you how to do that. There are other experts and other support services. But we are going to really spend some time with you reviewing the sample tools like Partner Health and other examples, and you'll see a living example out of UTMB and our friends down in Galveston, Texas, who've been doing this work for almost 2 years now. And what's important, and we're excited to know that some of you are new to this particular theme or to this series of calls and activities. And just to let you know, there's a lot of background information in the first 4 webinars that have been conducted by Karen and myself and available through Engage. So don't feel like you're jumping on the train too late. You're jumping on just at the right time. And there's lots of support materials we'll make available to you. But our objectives for today really are to work on the family engagement and to improve their role and care partners in helping people to recover from surgeries.
And I'd like to add just one more thing is we call the family members who support their loved ones in the hospital care partners. And we have sort of an introductory deck and workshops that we worked on with Boris during the month of February. So that gives a lot of good background information on just sort of the rationale of why family members can be so helpful to supporting your own patient safety goals and prevention of readmission goals. So with that, I think we will jump into Boris, would you like to introduce Meredith?
Oh, I think you will introduce Meredith later on, Karen. So okay. This is just the slide that we have on all of our webinars, so you can see our faces and yeah, and so Dr. Mary Foley was speaking previously. Karen Curtis, who is the executive of Partner Health and our primary partner for Track 2, and then Karen is bringing Meredith from UTMB in Galveston, Texas, as it has been mentioned, and so I think you'll introduce her more. But we're just thrilled to have Meredith be able to take the time to spend this hour with us. And at the bottom here, you can see the team here at HQI that's supporting you in this work. And I think now, Karen, I'm going to kick it off to you.
Okay, thank you. So we like to start our sessions lately with just checking in with you to see if any of you have been able to take the concepts or ideas and bring them into your own work.
So if any of you, the hospitals that are on that have been working with Track 2 or anyone else has an example they'd like to share verbally, we didn't have time to add additional slides or content. We'd love to hear from you and perhaps connect for an opportunity in the future so that your work be showcased. We really want to celebrate other people doing their work. And if we don't hear any, we'll just go ahead into the program for today because it's a pretty rich one, and I think you'll be pleased hearing what they've done down in Texas.
But we're always open to your calls or emails.
And you may be on mute, so we'll give you a second in case you need to unmute.
Okay, I think I'll move on, but you can always call. So today we're focusing on surgery, safe surgery. And the low-hanging fruit in this arena is really among those planned admissions. And the reason why is because there are so many touch points that you have with people who are planning a surgery, whether it's inpatient or outpatient with your hospitals. And of course, they have to bring someone with them. So this is sort of this low-hanging fruit illustration shows the various touch points, waiting rooms, pre-op testing, as well as the various forms of communication. Most of these are routine. You're routinely offering classes for certain conditions. You're routinely calling for your pre-op phone calls and scheduling tests and so forth. So this is a natural group to focus on. You have not only people who are charged with coming with their loved ones, but they need to stay as well. So another great touch point is the waiting area, where people sit there with nothing to do. I mean, they've got their phones, they've got the newspapers or books that they've brought with them, but they're just passing the time. Their focus is on their loved one, and they're probably anxious. And when we say care partner and we say family member, we also say, the equivalent is the close friend or trusted neighbor or whomever is that person the patient has designated to be their, provide logistical support, but also emotional support. So that family designation does extend to, friends and others. So the care partner is also present usually during the discharge conversation, especially if it's outpatient. And the care partner is present if the patient is admitted to the room. So these are all times when it is reasonable and logical to have conversations with care partners and to give them a little encouragement and tools for safeguarding their loved one's care. Now, during pre-op testing, the care partner might not always be there, but that's a perfect opportunity to ask the patient, well, who's coming with you? How, with your permission, may we contact us? Because we have some very, and this is an example, some very useful checklists of the kinds of things that they can bring with them in order to support you and to give you some peace of mind so that as we're taking care of you, there are certain things that your loved one, your care partner, can do. For example, we always encourage people to take notes. Who better to do that than your care partner? We have also a nifty guide for planning for your care and support after you leave the hospital, and we'd like to share that. So give the patient reasons why it's beneficial to them to contact their care partner, the person who's going to be with them in the hospital, with some helpful tools. And so therefore, that's such an opportunity to really communicate the message, we are a team, and we want to work together with you and support you. You may offer at this time a link, information about the link to your website page, which has, every hospital has good information for patients and their care partners. They call it visitors sometimes. And it would actually even be great if you had a special Facebook page, for example, that's just for care partners. One other idea, you can adopt this or not, is that when you're with the patient during pre-op testing for a surgical procedure, you might want to give them a label that they can affix to their gown, just to help them to be able to communicate when they're there for surgery. Chances are they're a little bit anxious, they have some concerns, and this is something that could be downloaded off the internet, off your website, or you could give them a sticky label. And it's basically just a way to communicate, sort of that last step of, just making sure that the site is marked if there's a left-right issue, any concerns that they may have. For example, one person we know really embraced this label and wanted several because when she was going into surgery, she had to give up her hearing aids. And she actually reads lips very well, and she wanted to make sure that she didn't miss any information. So she wrote on her label, "Please face me when you're speaking because I need to read your lips." And that gave her great peace of mind that she would not miss any information. So it's just an opportunity to communicate. I know I'm in good hands, but here, these are some special concerns that I have. It's just a way to honor the patient's special needs, perhaps, and to help ease anxiety. Another opportunity is during the pre-op phone call. You can do one call to the patient and to the care partner separately. You can restate the information from, did I miss this? Oh, I've kind of got two slides mixed up. But we encourage you to send a warm welcome note to the patient's care partners. It can be a printed version, or it can just be a quick email that basically says, you're coming with your loved one. Here's some things that we think that would be helpful for you to know, and you can attach that plan for care post-discharge so that you know that when the patient leaves the hospital, you have peace of mind and the patient has peace of mind that someone has been thinking ahead as to how to get that person who is still very vulnerable to the doctor's appointment, get the prescriptions, make sure that they have the right food in the house, make sure that there's somebody coming in for making them lunch if necessary, or helping them to bathe at night, or whatever those things are where someone may have special needs or even some particular deficits after leaving the hospital, that there is a safety net in place by having the care partner plan ahead for these very specific needs that patients have when they leave. When the care partner is waiting during surgery, we can give them something to do. All of these, this is the warm welcome note, and I'm sorry that it's out of order. But in the warm welcome note, too, that you can send out, you can make sure that the care partner understands that their insights are very valuable. No one knows the patient better than they. And so just to give that permission to speak up and share their insights and information is very welcoming. And so the other two things that we hope that people will emphasize to care partners, that hospitals will emphasize, is that they can take good notes, and that will be helpful to the patient, plan ahead for care and support after discharge, and wash their hands. So it puts everyone on board to help prevent infection from the very first moment. When you use your waiting room with all of the people that are waiting there who are reading or surfing the internet, you may want to consider enlisting volunteers. who are trained to share the materials that you may develop for how to prevent infection, how to prevent falls, how to prevent readmissions with the closed discharge care plan, and how to take notes. You might want to consider putting a warm welcome poster on the walls with the 3 to-dos that are so important: speaking up, washing hands, taking good notes. And then you may want to offer a kiosk with such materials. If you have a welcome video just for care partners, that would be appreciated too. So here is just a little illustration of, a care cart, if you will, that volunteers or others may be trained in order to take around to the waiting rooms and, give them a bottle of water at the same time, or a cup of coffee, or whatever you feel like sharing with them, just to introduce them to the hospital and to the importance of their role and how they may be able to do some very small things that could potentially make a big difference in how well they recover from their surgery, how well their loved ones can recover from their surgery.
So before we go on, and Meredith's going to have a great section. This is Mary. I just wanted to insert here. I think that waiting room idea is a missed opportunity, and I know some of you are probably thinking that you don't have the specific discharge orders yet, and that's very true. But everything from cataract surgery to knee surgery, or placement of a central line, where I've been through that once with a partner, my own partner. There are general descriptions and precautions and what to look for and how to care for that kind of individual post-op. That would be very useful to just give somebody a foundation and background. They may not be the loved one, and Karen and I keep slipping into our loved one relationships because that's who we've been involved with. But I know I have a friend who's in her 80s in a retirement community. She has a circle of people surrounding her who are becoming her care support during her new cancer diagnosis. They're her drivers. They're going to visits with her. But there's no one person that she has left as family. That's okay. She's got a network of people, and they all still need to know what's the next procedure, what can we do when we get her home, what will she need, what should I be watching for. So the general information as early as possible before the stress of getting the car and the person already appearing to you in the wheelchair may really get a head start on that information and really give people the confidence that if called upon, they'll be able to step up and be more than just the nervous driver or the person who's going to take somebody home and just cross their fingers and hope it goes well. So we just wanted to recognize the difference between general and specific instructions, and it could cut down the stress of those specific discharge instructions if the background is laid out in advance.
So with that, thank you, Mary. I'd like to introduce Meredith Maisel, who is from University of Texas Medical Branch. She's the director of the Oliver Center for Patient Safety and Quality Health Care. It does a fantastic job there, and she has literally been immersed in family engagement for the last 2 years, and we welcome her expertise and the benefit of her experience today. Thank you, Meredith.
Thank you. Glad to see everybody on the call, and please feel free to interrupt me if you have any questions. Just a little bit of background on me. I became a social worker and followed an administrative track because I'm very interested in programs and program management, and got my PhD in social epidemiology so that I could evaluate the outcomes of the programs that I was planning to run. Somehow I became lucky enough to land this job, which is a patient-centered pilot program workshop, basically. I'm funded by Carrie Oliver, who gave generous donation to the University of Texas Medical Branch to help doctors, for the most part, run pilot programs to see if we can make patient engagement happen, help doctors provide better care and see what works. And so I have a lot of flexibility that some of you don't have, but I work in an environment that is very strict on the other side. So if you have a question, well, how could you do that with limited resources or whatever, I'm happy to answer that as best I can. This all began with our orthopedics department. We selected total hip and knee replacement patients because it was a very planned surgery group of people, and the orthopedic department was telling the administration that we were having a low participation rate in the pre-op patient education. And Karen and I worked for a very long time to develop some of the materials you're going to see, and I will talk to you a little bit about how we've implemented it, what I've seen, and some of the challenges or things I'm excited about moving forward. I just wanted to say one thing about that care partner being so important. I was speaking to a friend about this yesterday. If you've played the game Taboo, where you have to guess a word and you can't say any of the other 5 words on the card, I could say to my best friend, the reason we hate Mosquito Cafe, and she could say, cupcakes. And that kind of communication you only have with someone who you're really close to. So they know you. They know the little nuances in your voice or the things that are being said and how to read that and interpret that to the people providing care for you in the hospital. So they really do have this in-depth knowledge that we've got to take advantage of. Our intervention is from clinic to discharge, and we start with I'm moving the slides, these goals. How do I move the slide? Next page. Okay. What we wanted to do with implementing some of the safe and sound tools were to improve our outcomes for the patients. We want them to come to the class, especially with a care partner. The class has somebody from every group who will visit them in the hospital, with the exception of the MD. We lost the MD. But an inpatient RN, an outpatient RN, PT, OT, care management, someone comes to speak to them, and they can ask questions at that time, and they learn about what to expect when they get to the hospital. It's hard to get people there. We have a pretty low income, low socioeconomic status patient population here. Also, who wants to go to class, and we weren't really getting much support, I guess, from the physicians about getting the patients to class until we added it to an order set. We want to possibly reduce readmissions, emergency department visits. We think that being involved in this kind of program will help staff feel more engaged in patient-centered programming, patient and family-centered programming. That has been probably the most difficult part of this process. And we do have a very serious commitment to patient-centered care here at UTMB. And over the time, we have targeted every single patient who is scheduled for a total joint replacement, hip or knee, since probably August. We've been intervening. As you can see on the slide, we were going to hope to get to at least 200 patients and talk to their care partners. We have materials in English and Spanish. It's one unit, so all the nursing staff who's involved can learn from each other. We check in regularly. It's very controlled, so we could find out what kinds of problems they might see. Someone said to me, "What's your rollout plan for the hospital, I said, I don't have a rollout plan. You can't roll out to a whole hospital after just checking in with one department with planned surgeries. But I do have plans now for rolling out portions of this program. And that's something that you can really take away from this today, hopefully. We plan to survey all of the providers, family members, and then look at the data after surgery. And I am going to do some in-home visits with patients within the 30-day discharge window and bring a care manager with me to see if we can have a very more in-depth interview with them and what their experience was like rather than just the phone call. And that will help us possibly create more questions for future surveys. So we have the toolkit. We are trying out a lot of materials. Some of them are going great. Some of them I'm not sure if they're being used, and some of them so far are not being used, but that's what we wanted to find out. So we send a warm welcome card to the patients. I'll tell you about that a little more in a moment, to remind them to come to their class. They already get regular reminders, but this is a different kind of reminder. We encourage them to bring a care partner and identify the care partner in the hospital with a name tag that says their name, the relationship to the patient, and the patient room, so they can walk around and not accidentally leak the identity of a patient. And then a blue Livestrong type bracelet that they can wear and easily be sought out by a staff member who can spot that bracelet and know that that's a person who they can talk to or has at least been involved. We've posted posters all over the unit. And one lesson learned from this is it's hard to put stuff on the wall in your hospital. So I threw a wrench in this and asked Partner Health to help me find a way to get a poster that can be removed easily from the wall without messing up any paint or anything like that, can be wiped down and cleaned. So it's a little bit of a vinyl finish. And if the room is contaminated and it needs to be taken out, we don't have this expensive glass frame that's going to be just destroyed. And it's gone very well. So far, so good with that. We offer them the opportunity to look at ebooks to prepare for surgery and prepare for discharge. That has not been very successful so far. I think it may be a little bit due to our patient population, but we'll look into that again at some point later. We provide them with a daily care notepad that has prompts for questions that they might want to ask the staff. We also give them a pen. So you know when you have patients in the hospital, sometimes they're taking notes on the back of receipts, they're looking for a pen, they are writing little bits of information on the corners of a handout you've given them, and there's not an organized place for all of the questions. The Daily Care Notepad has been very successful in that it has prompting questions, empowering the family member to ask. Also, I think a benefit of it is that the staff know what questions are coming every day from the patient's families. So they can start to get into a routine of preparing the information ahead of time, because these are the questions that are going to be asked of me, such as, what is the plan for today? When am I going to have my MRI or whatever? We also send them home with a plan for care that's introduced to them at class and also in the hospital, so they can start thinking about what are they going to do when the patient goes home. And I tell them how important this is in class, and I'll give you information about my approach that I think has been successful with getting patients to use this. Finally, this is sort of a psychological experiment. Karen has provided me with 8.5 by 11 size magnets that have signs of trouble on them. And there are all kinds of symptoms you might see that are worth calling our 24-hour clinician helpline. There is a nurse answering that phone 24 hours a day. They can advise. They can get you to talk to a doctor in that specialty if you need to. They can possibly save you a trip to the ER. And I encourage people to give our nurses who are on those lines something to do at 10 o'clock on Saturday night, because waiting till Monday is very risky. But the magnet, we think, would be really hard to throw away because it's kind of heavy. It seems odd. And so I thought that maybe it would be more likely to be used. It doesn't slip through the car seats as easily as a piece of paper does. So kind of curious to see if people have it on their fridge. And next, I'll describe the warm welcome. I was telling Boris this earlier. This has been the most successful part of our intervention so far, in that we send a reminder card to the patient and care partner, and they're already getting normal reminders. They get something in the mail. They get a phone call. But this card it's shaped differently. It's kind of like a thank you note size. There's handwriting on the front, so it's hand addressed. And inside, it's a little bit different than what you would normally see coming from a hospital, especially the outside too. You mean the world is a very, very nice thing to put out there. And I think this has been successful for several reasons. One, the age of our population. We think they may be more inclined to open and read snail mail that has handwriting on it, rather than every UTMB envelope looks the same and could be a bill or a survey, and you just might ignore it. The left side, I don't know if you can see it, but it says your class is on this day, on this date, at this time. And writing out the day, I believe, is, and this is just my idea, writing out the day, I think, was a genius addition to this card that Karen made, because I think it's much easier to remember I have something going on next Tuesday rather than I have something going on the 26th. And then it's signed by me. We don't have any contact information, but people have looked me up and contacted me before instead of the clinic to say that if they can't make it. And since we implemented this, we have greater than 100% increase in participation in the class. We're at over 100 people now. And before that, so we've been able to compare that, statistically significant, obviously, at over 100% improvement. Also, compliance to going to the class is very high. The last I checked, we were at 88% of people who were referred to class and received the warm welcome were coming. I just did a little look at the end of January through the beginning of May, there were 43 people on that list. Three were listed as no-shows and to the class. One of them still hasn't had their surgery, so something's gone on there. And I don't know what about the other two, but that's over 90% compliance. For those of you who are considering mandating classes for certain procedures or areas in your hospital, it would be wonderful to have another way of getting them there than saying you can't have the surgery here unless you go to this class. The welcome and the getting there on their own, I think, has been a very, very nice way of reaching the patient and the family member.
Meredith, can I ask you just a follow-up question on this? Is it only because, have you done other interventions or anything else in the same period of time other than this warm welcome card that might have affected that 100% increase that you mentioned, or is it all really attributable to this simple card?
I haven't done a multivariable analysis, but I get that question a lot, and I've looked at age, doctor, surgeon, gender, and I can't see anything else at this point. The class has been in the order set since for a long time now, well before we started this. And quality improvement has known for a long time that people aren't coming, and I can't see a difference in those who are being referred, numbers of people who are being referred now versus before, because you don't have to use the order set. You can pick which orders you'd like at the clinic visit when they decide you're going to have surgery. So there is a particular order for the class, and every once in a while you'll see that a provider did not order it, and usually there's a reason behind that if you look further, like they had the surgery on the other hip last year. And so I think we have the same number of referrals to the class. At this point, I can't find anything else. I don't know.
Amazing. That's great.
I was so surprised. We're all surprised. And
fantastic.
I'm just going to go with that for now. I walk around saying I think it's because of the card, unless I'm talking to Karen in private and I say I think it's because of the card. But anyway, we know that those who come to class do better than outcome-wise than those who don't, based on past quality improvement data provided by our hospital. And so when they go to class, I show up, tell them I'm the person who sent them the card, and enthusiastically tell them how wonderful it is that they're here. I guess this slide didn't come out totally, so I'll skip to the next one. But I praise them over and over. You made the right decision by coming. Thank you so much. You can do this at pre-op testing for other things. Just telling the person that it's so great that you brought somebody with you. That's going to help you have success with your surgery. Very encouraging language and smiles to tell them you are really going to be successful, I think is a good psychological approach to making them feel like they really are part of this. We do that pre-admission. During the boot camp, I give them the Signs of Trouble page that later on they get as a magnet, and I tell them it would be my dream. I could die that this year if every single patient had someone checking on them every day for 30 days after surgery. I give them a planning calendar at class, but also during the hospital stay for them to start thinking about who's going to help them. And at discharge, hopefully they will go home with plans for care, an understanding of their medication, and daily symptom monitors.
I would like, Meredith, can I interject something?
Sure.
I hope all of you notice the way Meredith presents the information with really a touch of heart, saying I would, die happy if you had, if you had a good outcome here, and then she gives them the tools. That is exactly the head, heart, hand model of communication that Mary and I try to role play every single session with all of you. So we don't really need to do that today because Meredith has already modeled this beautifully. Yeah.
Well, I didn't do it at first, and then I started more and more getting a little more personal, congratulatory, acknowledging the time that it took for them to come here. It's a Tuesday afternoon. It's during work hours. Just lots of applauding. It is a big deal that they came, and they should be acknowledged for that. And I get a lot of nods in the room when that happens, and I like to see that. Also, since we started this, we have a lot more care partners in the room, and the room's getting quite full, we've noticed. So,
Meredith, what is JIT?
Just in time.
Just in time, got it.
Just in time, yeah.
I'm going to roll through these next few slides pretty quickly because of time, but I think that you'll find some interesting information. So as I told you, we had a very, very big increase in attendance to the class. And I went ahead and looked at some patients who had the surgery before we started the intervention and had the surgery after we started the intervention, and I kind of peered through their EPIC chart. So I just want to tell you a couple of things. Here are 4 patients pre-intervention. Patient 1, these are completely random, I promise. Patient 1 was a no-show to class. Less than 30 days post-op, they called about how to care for their wound and asked the nurse to also talk to a home health person about how to care for their wound. They also called with questions about icing the knee and how many times a day they could do that for swelling. Patient 2, pre-intervention, was also a no-show to class. Less than 30 days post-discharge, they called and received immediate instructions to go to the ER. They had an ER visit. Days later, they had a DVT and a readmission. Patient 3 did go to class. They were doing well at their post-op appointment and going to PT as instructed. And patient 4 was also a no-show, was doing pretty well, less than 30 days, but did call about pre-op and post-op medication confusion, which is addressed in class as well as probably at discharge, and we do have a medication paper for them. Post-intervention, my first patient attended class, had no events less than 30 days. The post-op appointment was attended by their care partner as well. Patient 2, same thing. They were going to PT, and they were also complying with their anticoagulant encounters. Patient 3, same thing. Then I was trying to find a no-show since our intervention, which is hard to find. So I found one, and it turned out the surgery still hasn't happened because they've canceled repeatedly. So then I looked for another no-show and to class, and they had a abscess and readmission within 30 days. And so we've got to look at those people who are really not engaged from the start and maybe target them. Our nurse comments so far, the notepads are number 1. Patients have seemed more knowledgeable the last few months and that they've really noticed a difference. One has told me that they don't think the ID and bracelet are used because they're not asked to put them on. They're just told about them. And so I'm going to try for a different language approach to that. And some have complained that the magnet is too big to fit on their fridge. Had a few patient comments. One, I'm glad I went to class. I would never have known that my equipment wouldn't be reimbursed if I bought it up front. I haven't used all of the things referring to the Safe and Sound materials, but I was glad to have them. And one who said we did not really use the papers. My next step is to look at Press Ganey and see if we can find some information in there. Lots of lessons learned here about tracking in EPIC. That's a whole other webinar. I'd be happy to talk to any of you afterwards about how difficult it has been to find the information on what we need to know post-intervention in EPIC. So, wrapping up, the benefits for this, I think we've seen people are more engaged by coming to class. We've had more participation from care partners, and one of the doctors told me that it's nice to see that someone cares. I actually called him with a concern about a patient because I thought he was doing something wrong, and I had to have a crucial confrontation. And at the end of it, he said, well, you're wrong, but it is nice to know that someone cares. Our challenges have been with nursing staff because RN time is very difficult to get. I can't get them in meetings. I can go to their 6:30 in the morning change-off meeting and talk for maybe 5 minutes, but we're doing 3-day, 12-hour shifts right now, and it's very tough to get to the nurses. My advice would be to role play with the nurses if you can do that. And as far as the intrinsic value of this for the different people involved, for me, it's I feel very committed, and I've seen changes, so I know that I want to follow through and finish this up. The patients and care partners are shown that their time and participation is valued, if that's the very least. I've learned, and many others have learned a lot about problems we have with our electronic medical record. And now I think I need help finding a way to reward our nurses, to make them feel valued. I'm going to bring them data, but I want them to feel good about doing it, with doing this with the patients, and I need to figure out some more ways because I think that our nurse participation is the biggest challenge. So finally, I would love to add audio recording at discharge, which is another one of my programs, but I'm not going to do that until we finish what we're implementing now. And I think that would also boost complications post-surgery or post-discharge. So, Karen?
Yes.
So would you like to take over at this point, or?
Yep. Yeah, so Meredith, that was awesome, and thank you for your belief in this, and you're willing to test it, and we'll move heaven and earth with you to get into EPIC and Cerner and all the other systems so we can validate this work and make it easier to extract and make it part of the permanent flow of information. So thank you for this. Karen mentioned, and we'll be very quick because we are coming close to the end of our hour, this is our standard rubric. This is the using the brain to share facts, finding the heart to motivate, again, the person in the waiting room, the person who's transport, could be a loved one, could simply be a neighbor. They still care. There's a reason for them to be there. Whatever that reason is, that's the motivation to engage with them. And then the ability to provide them some tools, the brochures or the materials that they might need in advance of having to be the responsible party taking someone home. Very helpful. This is also the QSIM process, Quality and Safety Education for Nurses, and we're partnered with them, and it's exciting to see the similar methodologies used, because we know they work. This is how people learn the best. It's also been demonstrated that they are able to retain the information best when learned in a variety of ways. So we're very happy to say that this has been successful.
Okay. I'm trying to advance the slide. Do we have the?
Maybe that's my fault.
Oh, okay. So we were going to do this role play of how to transfer this gentleman's attention from Facebook to the volunteer who wants to welcome him and share materials. So Meredith, maybe you and I can do that. Or Boris, you could be the guy who's on Facebook. And Meredith, do you want to take a stab at this, or do you want me to?
I'd like you to. I want to hear
Okay.
another way.
Oh, I don't know. I think you do a great job. So, Mr. Boris, Mr. Kalan, thank you for taking so much time to be here and to wait so patiently while your daughter is in surgery. May I get you anything? Can I share this bottle of water with you? Do you have any questions for me?
Thank you. No, I'm just kind of a nervous wreck. I really, I can't get my mind off of what she's going through right now. Hoping everything's good.
Yeah, I'm so sorry, and I'm sure they'll come and update you as they have information. What I would like to share with you is just how we might be able to support you in supporting her recovery at home. We have this handy checklist for you so that you can go through some of the special needs she'll have at home, and maybe even some of the medical care you'll need to coordinate further for her. We find that this is very helpful to think ahead before you're actually at home, and we know you don't want to leave her there to, run to the grocery store, run to get prescriptions. So we find that this planning ahead gives everyone peace of mind. Can I share this with you? Would you like to look it over just while you're waiting?
Yeah, no, that sounds good. I'll take anything you have.
Great. We also have this notepad because you're going to get a lot of information while you're with your daughter in her room. And sometimes it's hard to know what details are important, and sometimes it's hard to know even what questions to ask. This is not, your day-to-day routine. So we want to help you feel prepared for those conversations with your doctors and nurses. Here's a notepad and a pen. Do you think you'd like to take notes, or?
Yeah, notes would be great. I've got my little piece of paper here, but yeah, your notepad is better, so thank you.
Okay. Well,
right.
We have more materials here on the cart. I don't want to overwhelm you, but if you have other questions, for example, we know that everybody is prone to falling in the hospital just because it's in an unfamiliar place, and people have been taking medications that sometimes make them drowsy. So if you'd like to know how to help us in our vigilance to prevent falls, we have that material here on the cart. Please help yourself. We also have a kiosk in the corner where we talk about, how to keep your daughter free from germs that are just, everywhere in our everyday life. We have all of these resource materials for you, and please help yourself.
Thank you so much. This is very helpful. And I actually see the surgeon coming out, so let me try to catch him right now, or catch her. I think she may be a woman.
Okay.
Great job, Karen. And I think we're at the end of our time. So let me just remind people that emails are at the bottom of the screen. If you folks have any questions, or I realize we didn't leave a lot of room for questions and answers, and maybe nobody has any. But if you do, just reach out by email. We'll respond very quickly. You've got everybody's emails right here on the screen. And let's keep the conversation going. But we do look forward to seeing you at the next session on August 15th, Partnering to Prevent DVT and PE, deep vein thrombosis, and pulmonary embolism. And then keep in mind the capstone event that I mentioned on September 16th. And with that, I would love to thank Mary, Karen, and Meredith for sharing their knowledge and experience today. And thank you all for attending, and have a great day.
Thank you. You too.
Thank you for hosting.